It's Healthcare Unfiltered, and one of the people I admire the most, Jill Feldman, is with me on today's podcast. And Jill and I are neighbors, actually. We don't run into each other often, Jill. We got to change that.
I know it's crazy. We live a mile and a half apart.
We live like 2 blocks away from each other. It's crazy, isn't it? But we gotta change that. We're gonna change that. Hopefully
Yeah.
soon we'll meet and we get a cup of coffee. Well, welcome to Healthcare Unfiltered. Thank you so much for joining me.
Well, thank you for having me. I really appreciate talking with you, and I love the topics that you tackle, and appreciate you including the patient perspective.
It is beyond important. At the end of the day, it's really, first of all, we're all patients. And if we're providers, we are really helping patients. So learning from you is very important. But before we get started, just a bit about you because you were diagnosed with lung cancer, and I've had you on the show several years back. But tell us a bit about you and how did you transform from a patient to a patient advocate, and what does a patient advocate means?
Yes, that's a really good question. My story is quite different than most people because I got involved in advocacy before I was diagnosed. I had the family history of grandparents and both my parents and my aunt dying of lung cancer. So when I first tried to get involved in something back in 2000, there wasn't anything at all, no walks, events. And I always say coincidence or fate, the first organization in the country dedicated exclusively to lung cancer research was founded here in our community, actually Northbrook-ish. And I got involved shortly after it got off the ground. And in a million years, I never thought my role would evolve into research advocacy. In the beginning, we needed to get people to care, we needed to raise funds. So while I was busy doing all that and educating myself, I was diagnosed with lung cancer in 2009 at 39 years old. And my kids were 6, 8, 10, and 12. Their only association with the disease was death. They were scared. My biggest, fear became reality. I was following in my family's footsteps, and there still wasn't any promising research that convinced me my path would be different. And that's when I first started getting involved on, looking at both sides and trying to bridge that gap between science and humanity. And that was, back in 2010. And so it's a whole different cancer world now, as you know, with advancements in research and treatments that have really revolutionized the way that we treat cancer. But as all of that evolved, my advocacy continued to evolve, and I think, was able to have a perspective because I had been an advocate, I had been a loved one, a caregiver, and now I was a patient. I had a different perspective than most, and I really looked at different things that people weren't necessarily paying attention to. And I think I tend to also be passionate about a lot of things. So there was no roadmap. Again, science was my worst subject. I just kind of followed what the community needed and what I could influence. You can't change the system, I've learned, but you can definitely help influence changes.
And you actually, I mean, you have a very, very powerful voice. And what I love about your voice and your comments is that you could tell that you genuinely care about people. I don't think most patients or families have the level of knowledge that you do. Um, And I appreciate the fact that you try to bring that to everybody, no matter what their level is. One of the reasons I've asked you to come on the show, Jill, is that recently, over the past several weeks, the World Congress on Lung Cancer has concluded in Barcelona. And everybody interested in lung cancer goes to this meeting. Um, Several thousand people are there. And there's a lot of data, lots of information. So tell me, first of all, why do you go there? What do you view your role in going there? We'll take it from that, and then I want to try to understand how you digest the science as a patient and advocate. But why do you go to WCLC?
So when I first started going to the conferences, I went because I wanted to learn, and I went because I wanted to connect with the scientists. So that's why I first started going. I was not part of the faculty. I wasn't asked to speak or mentor or anything like that. In fact, patients didn't go to
Right.
conferences, 10 years ago. But so I started going for that reason. And then, I kind of, I kept going to conferences, I realized that there was this need. It was a two-way need. There was a need to be able to take the information learned at the conference and disseminate it back into an accessible information for the community, and would tell it in a way that they can understand. So that was needed. And I saw that the other need really was that there was a part of the story that was missing. So you've got the science, and and truthfully, it's like, going to, the Grammys or whatever you're going to, and you go, and me too, you're excited to anxiously awaiting data and spotlights and numbers. Numbers and data get the spotlight, and they tell a very important story about, hazard ratios and statistics. But what often gets lost is that there's another part of the story, and that behind every data point is a person and a family that are profoundly impacted beyond statistics and beyond survival. People don't want to just survive, they want to live. And so that, there was kind of that disconnect. Survival's the destination. I get that. But living is about our experience in between. So those still are kind of the two needs that, and the reason that I continue to go to a conference. And especially, if I'm asked to speak or participate, the first question I ask myself is, will I provide value? Is there someone else that could do this and provide value? And what is in it for my community?
So have you noticed that over the past, and you've been going to these meetings for several years, what has changed in these meetings from a patient perspective?
So a lot has changed, actually, and it depends on the meeting. World Conference, there are advocates there now. There's a research advocates training program that we have. And in International Association for the Study of Lung Cancer has been really great about integrating the patient advocate voice on panels and or speaking within a
Hmm. Hmm.
session. So that's been really great, I think. And at other meetings, I was at AACR in March, and I was on the planning committee this year, and was able to actually they influence a major symposium on survivorship. It was the first time ever that they've done that. And so I think they're listening more. They're understanding that that they need to include the people who have the lived experience. No doubt, clinicians, scientists, experts in the research, in the science, in treating people and cancer. But we're the experts in the lived experience. And you really need both for research to be both rigorous and meaningful so that it translates into improved care.
One of the things that you are very passionate about, because I read a lot of comments on you, is what I label that under quote unquote language matters.
Yes.
You talk about a lot about that. Tell my listeners what you mean by that, and are you seeing improvement in that domain?
Yeah. So language, when I talk about language, it's words, it's body language, it's tone. I think, and I just have to acknowledge medical oncology jargon wasn't created with patients in mind. There
Right.
was no thought that patients were going to be reading their clinic notes, reading journal articles, going to conferences. So this was all language that was used back then. And for me, what happened was in lung cancer, there's the stigma. And it was probably about 10 years ago, 11 years ago. Now I realized that people diagnosed with lung cancer, every single person is labeled and categorized by their smoking history, whether they ever had a cigarette or not, right? You're either a smoker, a non-smoker, former smoker. And what that does is we're not even people. I remember back with HIV when they said AIDS patients. They had patients after their name. This label has nothing, and it really it allows researchers or clinicians to disconnect with humanity that way. And it in the research that I've done on that too, really, I was shocked at how powerful it could be. So I realized after all those years, after 12 years of advocating already, if the stigma is never going to go away if we continue to categorize everybody by the stigma itself. So that's where it started. And the International Association for the Study of Lung Cancer, we did the language guide on person first, stigma free, blame free, meaning patients don't fail treatment, treatment fails patients. Or when we use the word compliant or non-compliant, we're not recognizing that maybe some people don't have transportation, or they're not able to show up for an appointment, or they can't take their drugs every day because they can't afford to get them once a month. And so, but these words are really, when a patient reads them, it really hits hard. And so, and I think we really need to be conscious of that now. So, and equitable and inclusive language. So it started with that, and then recognized that, well, it's hard if we're going to use person first, say a person with a smoking history. It's hard to actually get that into word count limits. So we just released the second section on using abbreviations. We worked with tobacco journal articles. We worked with AACR, ASCO. We really tried to include everybody because we can't make decisions on abbreviations. And so that's where it kind of started. Now I'm leaning more towards changing the way we talk about science, and two parts of it. One is subjective toxicity reporting, which we can talk about. But the other one is I worked with a company and they changed their lexicon for research. And so they were really interested in the research and being accessible to patients and loved ones. And so they came up with kind of a lexicon and kind of different levels of where the technical language is appropriate and where, they should use language that that people who are in the lay community can better understand. So that is the first company to do that. And really doing that, we went through kind of when you talk about adverse events, and what does that mean? And
Right.
side effects, patients, it's side effects.
Right. So with that, I mean, that's actually a perfect segue because language matters, and you give me a few examples, but one of the most important parts of language at these conferences is the data itself that's
Yes.
going to be presented. And I loved what you just said, by the way. This is probably the first time I see you saying that, but it so resonates, which is the language that has been used 20 years ago in the medical lexicon was not really created for a patient-friendly audience. I mean, frankly, how is the patient going to know what PFS is or progression-free survival? Half the fellows and residents don't understand PFS. So you go
Right.
to these meetings, and you're just sitting there, and all of this data coming through the slides and so on. How are you taking that information and interpreting it? Like, how is this data being consumed by patients? How is it resonating with patients? Do they understand the data? Do you understand the data? Do you have to go to AI and just plug it in and say, what does that actually mean? I don't even understand what they just said. Tell me the language matters from the scientific perspective, because at some point you have to take that in. And let's face it, if you can't understand it, probably most people with lung cancer will not understand it.
Right,
So
right.
tell me the language matters from a science perspective. How do you take it? How do you absorb it? And how do you consume it and then disseminate it outside?
So that, and it does definitely take a lot of work. I think I would say first, when the words used, the terms used, the analysis, the abbreviations, patients do not understand any of them. So when they hear survival,
Right.
that's what sticks in their mind. And so, there's this overall survival is the gold standard. But interestingly enough, patients really care about progression-free survival. That matters too. So what I really do is when I'm at the conference, I don't pay attention to the detail on demographics in this. I look at what the schema is of the trial. I look at what the endpoints are of the trial and then look in the data they present. So for instance, overall survival, say it increased from, by 10%, let's say.
Right. Right.
In my mind, I think about, okay, every percentage point represents people who are seeing their kids graduate, celebrating anniversaries, and it's really important and but not to everybody, right? So I'm looking at the survival. So then I also want to know, okay, what about what are the toxicities or the side effects? Because at the end of the day, my concern is that every single patient and family has the information for the options that they have, and they can make a decision based on their goals and their values. And that
Yeah.
means if, one study has, say, 3 month longer survival, well, then a patient should be able to decide whether that 3 months is worth the potential side effects. And so I try to gather that kind of data, but it's interesting because, you know, hazard ratios, let's say for,
Right.
I mean, they may be encouraging, but patients don't experience hazard ratios. They experience side effects, fear of progression, daily impact. So to me, it's about translating these statistics into meaningful life
Yeah.
and what the impact is. And so it's sometimes it's easier than others. I ask a lot of questions. I will ask researchers a lot of questions. Like, I don't understand what, probably a year or so ago, I just learned what PFS2 is. I had no idea.
Right. Right. So with that, take me through some of the data that you came out of World Lung WCLC from a patient perspective. What did you gather from that meeting that could possibly have an impact on you or on your fellow patients? Um, because again, maybe, and this is almost like, it's not like leading the witness, but it's really not leading the witness. But maybe there's a speaker out there who is showing data and they're talking about how impressive that data is and how important that is and so on. And you're sitting there and thinking, no, it's not. I mean, I'm the patient, so I don't think it is. And again, I'm not suggesting that this happened, but I want to take that example to understand what I'm trying to ask, which is you were there, you had a lot of these meetings. I want you to update us from a patient and advocate perspective. I do have other podcast episodes from a researcher perspective. And so I have this plan in my brain. I want to see how aligned the actual researcher and patients are in the interpretation of the data and the science at this meeting.
Right. No, that's a great question. I think, first of all, I want to say this is an exciting time. The trials are reshaping treatment for EGFR lung cancer, which was, one of the big presentations. And what does that mean? 30,000-foot view. This offers hope through options, right? So it is offering hope to people, and it's exciting, and we have to celebrate these wins. But and I think, when was it? In March, when I look at the FLAURA2 data, when I look at the Mariposa data, I think the first thing I think is this is exciting. These are options. Of course, we still need to do better. We don't need more treatments. We need better treatments. But it's really, really exciting to see, with both of them, like increased survival, not just by months, we're talking
Right.
years. That is really important. But I think the one thing that is that I think about, and I've talked to everybody about, is there's no one size fits all best treatment option for people. So these results really underscore the need for future research into biomarker, disease characteristics and risk stratifications to help us understand who benefits most from each approach. Because we are in the era of precision medicine, but treating everyone with the same dose is the complete opposite of precise, or with the same drug. And so I think, that is what really I when I hear clinicians or researchers talking about the data, I really would like to hear a more well-rounded conversation, because what I would have chosen when I was 39 with 4 young kids, I would have wanted that choice. I am not sure I would choose it now, but at that time I needed to be able to look my kids in the eyes and know I did everything in my power. And I'm a big quality of life, advocate, but I still deserve, I think all patients deserve the option so that they can look at the benefits, the risks, and
Right.
how it impact them. So the data is really exciting. A couple of things though, I think, there are certain things that aren't analyzed. There's certain data that patients would like to have that we don't have. And so I think that's an important part of looking at this data. And what do I mean by that? When you look at toxicities, you use the grading system in clinical trials. That's for safety. That is not for tolerability. And I'll say in a room, raise your hand if a grade 2 diarrhea is tolerable in the context of your life. And they laugh, right? Because it's an additional 4 to 6
Right.
loose stools a day. Yet it really is deemed tolerable because you don't need medical attention. Yet that, especially the chronic low grade toxicities that are persistent, I equate them to a pebble in the shoe. No big deal at first, maybe kind of annoying, but as the day, the weeks, the months, the years go on, and that pebble is rubbing up against your foot, that persistent, uncomfortable pain absolutely impacts every part of your daily life and tolerable changes. So that's the data that we don't get.
Right.
And they don't usually, I'd like to see data separate with the people who had dose reductions, because that would be important too to patients and their families, so that they could say, oh, look at this data. People who had a dose reduction, it didn't, the efficacy was the same, but they were better able to tolerate it. So
Was there a particular trial or presentation that hit home for you with more proper reporting and vice versa, a specific trial that you thought they should have reported differently or not necessarily?
not necessarily. No, I think for the most part, everybody reported, what they
Yeah.
were, what they were analyzing, the usual stuff. I do like it. There were subgroup analysis for some of the presentations, and I think that is important. It must be interpreted with humility and with urgency. And with the understanding that every subgroup is made up of people. And I
That's
mean,
so like stating the obvious sometimes makes you wonder, right? So, did you give a presentation this WCLC? I think I saw you giving a presentation, no?
I did. Well, yes, I was on a panel. I was on a couple. And I was a mentor for the STARS. Do you know the
Uh-uh.
STARS program? Yeah. So the STARS program is the training program for patient research advocates. And then I was on, there were 2 different sessions, and one of the session was a very important, topic, which is equity and in low and middle income countries. And that's always a tough one, and talking about improving the outcomes globally. That was a great one.
Yeah.
And then the other session was really on basically, the continuum of lung cancer. And I chaired that session, and it was a very impactful session. where you had perspectives from different people. And one perspective you would have really appreciated was from a caregiver, and really the
Right.
focus on personalizing the care from diagnosis to survivorship. And this woman, Shani Shiloh, talked about her husband, and she got up there and she said in front of everyone, she got to the point where she thought in her head and probably said out loud, "Would you just die already?" That, yep. I mean, it was like, I
Yeah,
don't think
no, it's
was it.
very, we laugh about it, but I know it's emotional. I'm pretty sure. I mean, this is a very emotional type of talk.
Yeah, so that was the other one. I thought that was a fantastic session. And the nice thing about having advocates chair sessions too is you ask different questions, right? So you're connecting and you're bridging that science and
Yeah,
humanity together. And I really, that it gives me the opportunity to, say, in so many words, let's prioritize quality of life alongside quantity of life. And
for sure.
the reality is that, you know, I w- patients don't experience survival separately from side effects, impact, milestones. And we need to keep that in mind, because when we fall short, if we're not focusing on that alongside survival, if it's an afterthought, we all lose, right? Researchers
Yeah,
lose data, clinicians lose insight, but we're not just missing data, we're missing the point, that the science that claims to help people, and most importantly, people suffer. So that, it helps, you can weave some of those important aspects into it, because otherwise it really you get into the woods with the science, which is so important and exciting.
I saw a post, I think, that you are starting a podcast as well.
No, 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 no,
Was that
no.
a guest? Yeah, okay.
That
You just
was
keep coming on my podcast. I like
Yeah,
that.
no, lung cancer RX. Uh, three early career investigators that I met when they were fellows. I call them my three musketeers. They're now all attendings, but I kind of connected everyone. They are doing a podcast, and so they had me as
Oh,
a
they had
guest.
you as part of the
Yeah,
podcast.
as
Yeah.
the guest. So it was great. I said I feel like a proud mom, because I've watched them.
So what else happened at the WCLC that you can take us in there more from a patient's lens, advocate lens, family lens? What else happened at the meeting in Barcelona?
I think, first of all, it really is welcoming to everybody. So the way the networking is incredible. The workshops, before the conference starts, there are workshops that people could go to. And actually, an advocate started a compassion fatigue workshop for the
Oh yeah.
clinicians and researchers, which, again, we recognize that all the clinicians and researchers need to be taken care of, so that they can, help
Yeah.
us, whether it's
Yeah.
taking care of us or research. So, there's workshops on that. There's workshops. I didn't get to go to the workshop, the session on AI for screening. I'm part of the Sybil Consortium because I had another session. But so there's all those opportunities, there's networking opportunities. And what is really neat about it is that, advocates can walk through the poster session, and all of the researchers take the time to explain their work to the advocates, and it's pretty incredible.
Yeah. Yeah.
I think the community is really embracing it. There was a lot of there was a lot of data presented. I just said to someone today, it was so busy. I missed so much. We almost need like another day now. This conference used to be every other year 15 years ago.
Yeah.
Now we need, another day. But it was really well rounded with, I love seeing more data on small cell lung cancer. That's huge. I cannot believe early detection is really kind of exploding. And the perioperative,
Yeah.
neoadjuvant, there is so that is kind of what I took away from big picture. It wasn't, oh, this was a huge focus. It was, wow, there's so much on everything.
Well, this is Jill. This is really wonderful. I mean, I think keep doing what you're doing. It's amazing. How are you doing health-wise? Can we ask?
Yeah, I'm doing okay. I'm stable. I had progression last year in an area. Thankfully, was able to go off the targeted therapy, zap it, and went back on the targeted therapy. I have some weird thing going on with my spine, but I don't think we don't think it's cancer. It's probably a vascular
It's
malformation.
probably you're working too much.
I know, but it's really, otherwise I have a lot of work to do. I can't can't afford to have too much going on. No. But really good.
Yeah,
I'm fortunate and I just, keep doing, I always say cancer changes a person's life, but how we live defines it.
for
And
sure.
how I try to define my life. So yeah, so it's great and it's exhausting. And as long as it continues to move forward, that's what matters.
Well, we need more of you in the world. I appreciate everything you're doing, and thank you so much for sharing some thoughts on patients, advocates, and how you interpret scientific data and these major conferences. Jill Feldman on Healthcare Unfiltered. Thank you.
Thank you. Thank you for having me.